everyone, so today we're going to be talking about commonly used lower extremity orthotics. So the first thing I just want to discuss is what are orthotics. Orthotics are artificial devices such as braces or splints that are going to help correct the biomechanical issues of the foot, the leg, or even the arms. So the first one we want to talk about today is for foot orthotics. So just some goals of foot orthotics is to support the foot in a desired position, provide relief to pressure-sensitive areas, redistribute weight bearing and for comfort, and to reduce plantar shearing forces. We also want to support the joints and correct deformities. So here's a picture of foot orthotics. They're just inserts that go into your shoes. So some indications for the need for these would be plantar fasciitis, heel spurs, DJD, flat feet, and posterior tibial tendinitis. So the second one we're going to talk about today are ankle foot orthotics. So just some goals of these are to help control the knee as well as the ankle and the foot, provide toe clearance during the swing phase of gait, stabilize the foot and the ankle. So the reason why these have control to the knee too is because it attaches just below the knee, so it can help give some stability to the knee as well. Alright, some indications for ankle foot orthotics are to drop foot, CVA, stroke, arthritis, ankle instability, paralysis, multiple sclerosis, or ankle fusion. So these are very common. There's a picture of them. They're going to attach just below the knee, go down the back of the calf and into the shoe. The next one we want to talk about today is knee ankle foot orthotics. So the goals of these are to control the knee. So it's going to provide the knee control because it attaches just above the knee, goes all the way down the leg and into the shoe. It's going to provide stability to the knee and foot during the stance phase of gait, and it's going to provide knee hyperextension control from the mid-stance to the terminal stance phase in gait. So here's some indications for knee ankle foot orthotics is instability of the ankle and the knee, CVA, stroke, paralysis, knee replacement, weak quads, spina bifida, post-polio, and cerebral palsy. And there's a picture. Like I said, they attach just above the knee, and it's going to support the knee, the ankle, and go down into the shoe, into the foot. Okay, the next one is knee orthotics. These support, protect, and prevent deformities of the knee, improve the ability and the quality of gait, stabilize the knee, and improve the function of the knee. These are really common with ACL and PCL, tears or repairs. They're also used for MCL and LCL insufficiencies, so these are really common. You're going to see these hinge braces just like this most commonly. Some other indications are osteoarthritis, knee instability, varus and valgus deformities, patella dislocations, and again, multiple sclerosis. Alright, we got one more. We're going to talk about hip orthotics. So these are going to prevent hip flexion or extension, and they're going to limit hip AB and adduction. Just some indications of these are usually after hip dislocations, hip dysplasia, and hip arthroplasty, which is a replacement. And it attaches around the hip and it's going to go down on the mid-thigh. So you might ask, what does physical therapy have to do with orthotics? So physical therapists are going to identify the need for the orthotics based on like a patient's range of motion, joint ability, joint alignment, voluntary control of their movements, their functional level, and their muscle tone. So us as physical therapist assistants and physical therapists, we cannot fit or make the orthotic. We just recommend that they need one. So the patient will have to go see an orthotist to have it fit and made just for them. So I have a little analogy for you guys. People are going to need to wear their orthotics all the time. Some people realize that and some people don't. Some people think that if they wear it for a little bit and their pain stops, then they can take it off. But just in reality, as soon as they take it off, the pain's going to come right back. So I kind of compared them to eyeglasses. So when you wear eyeglasses, your vision is fixed and you think, oh, I can see. Well, as soon as you take your eyeglasses off, you're no longer able to see like you could with the glasses. So orthotics work in the same way. They're going to correct the problem, but they're not going to completely fix it. So as long as you wear the orthotic, your pain will diminish. And it's the same way with eyeglasses. As soon as you take your glasses off, you're not able to read small print, and as soon as you put them back on, you're able to. Orthotics work the same way. And people just don't really realize that, so you have to encourage your patient that it's okay to wear them all the time and that it's going to help them. Alright, and I just have a couple pictures from some that we have in the lab. This is the ankle and foot orthotic. This is the adult, and then this is some pediatric ones. So a lot of times these deformities happen as kids, and then they have to stay in them the rest of their life and build them up. So we start out in pediatric ones, and then they'll get fitted for an adult one as they grow. And a lot of times, you can't really tell in this pediatric picture, but they have built up spots in the foot of them to take away pressure in certain areas of the foot that they're having pain. This is another one that we have in lab. It's the hip, knee, ankle, and foot, so it comes all the way up above the waist, and it's going to go all the way down into their shoes. So it's basically like the ankle foot orthotic on the bottom of a hip one that goes down to the knee. Alright, and there's some references that I used, and thank you guys so much for watching.